these are the classic findings or symptoms of someone with SLE. It's multisystemic, affecting different organs. So malar rash presents as a flat, raised, fixed erythema over the malar area. The malar evidences and sparing the nasolabial fold. So this is described classically as the butterfly rash of SLE. This white rash is also a possible feature. It is a erythematous raised patch with which is adherent and has keratotic scaling and follicular plugging. So scarring may occur in all lesions. Photosensitivity is a skin rash that is triggered by exposure to light. So remember our lecture, UV may be a trigger or may cause flares. Because of course UV can damage your nuclear component, thereby triggering the antibody responses to it. So arthritis can present as a non-erosive arthritis involving two or more peripheral joints that are swollen or tender, and effusions can also happen. Ulcers are mainly painless and are seen more in the oral cavity and pharynx as part of the cutaneous inflammation and damage caused by the disease. Sinusitis will often present as pleuritis with accompanying pleural drought or effusions. Inflammation of your pleural layers, right? And pericarditis as well, which may present with abnormalities in the finding of rubs, changes in EKG, or pericardial infusion as well. Then perhaps one of the absence of any metabolic or drug-induced causes. Hematologic complications of SLE can present as an immune cytopenia, an immune-mediated destruction of red blood cells, white blood cells, or even platelets. Immunologic features of SLE would be the demonstration of the different antibodies associated with it. A positive anti-dsDNA, for example, or a positive anti-phospholipid antibody, positive anti-SMID. And because of the production of various or many types of antibodies, SLE, it can cause a false positive test in other serologic tests, like tests for syphilis, for example. DNA, or anti-nuclear antibody, is an abnormal, it's an anti-nuclear antibody. It's one of the screening tests for autoimmune diseases. In SLE, you have an abnormal titer, which can be confirmed by immunofluorescence, or an equivalent assay in the absence of drugs that can be associated with the possible drug-induced lupus type of presentation. Now, for the general laboratory tests that are often requested for SLE and patients with autoimmune disease in general, you can request for the following. Of course, these tests are guided by the presentation of the patient for what possible complications are present. And these tests may reflect or may be helpful in reflecting or assessing the potential damage caused by SLE to that organ. So your CBC, a general test, we mentioned that complications of cytopenias can be a result of SLE. So therefore, CBC will be helpful in documenting decreases in red blood cells, white blood cells, and even platelets. So this can happen in a single blood cell type or combination. And with high levels of suspicions and supportive laboratory tests, of course, this may be an evidence of immune-mediated cytopenia. So serial CBC testing is also useful for monitoring bone marrow responses, for example, to immunosuppressive therapy. ESR is a test that reflects inflammation. It's a marker of inflammation. ESR, if elevated, is a useful parameter to follow with therapy. So it can be used for risk stratification as well. So other immune or inflammatory markers or your acute phase reactants will also be helpful. If you suspect a potential renal complication with SLE, then urinalysis and renal function tests, BUN and creatinine, can be helpful for diagnosis. So urinalysis is useful to evaluate proteinuria and any cellular sediments and gases. The 24-hour urine protein excretion and measuring blood, BUN and creatinine are also useful to assess the patient's renal function. Remember again, SLE is a common cause of renal failure. It's one of the more common causes of or indications for renal transplant. Liver function test and lipid profile is possibly done to evaluate a possible autoimmune hepatitis still triggered by SLE. So alterations in plasma lipids, either due to the disease or as a sequelae of therapy, can be appropriately managed to prevent cardiovascular complications. We mentioned that the antibodies produced in SLE and other autoimmune diseases can cause false positive results in serological tests. So one of which would be VDRL or RPR, screening test for syphilis. A false positive VDRL test is noted commonly in SLE. A positive VDRL in the absence of the organism is a diagnostic criterion actually of systemic lupus erythematosus. Antinuclear antibodies or ANAs are present in about 95 to 98% of patients with SLE. So this can be a useful initial starting test to diagnose an autoimmune disease in general, particularly lupus. So complement assays, so recall that SLE is the majority of symptoms of SLE follows a type 3 hypersensitivity-induced damage. It's type 3 because SLE forms numerous antigen and antibody complexes that can deposit in tissues. And if you recall our lecture on complement, the classical pathway of activation of your complement proteins are triggered by the presence of these antigen and antibody complexes. So therefore, activating the complement system will use up your complement proteins. So low complement values, therefore, may reflect an active disease activity. So these are the other autoantibodies present in SLE. So we have antibodies against your double-stranded DNA. It is the marker of active disease. So this line here is just the immunofluorescence pattern. You can measure it in the blood. You can also measure it by immunofluorescence. So for dsDNA, its titers fluctuate with disease activity, and it correlates best with renal disease. Anti-SSA or Rho is seen in subacute lupus, 75% of the time. It is also detected in cases where you have neonatal lupus with heart plaques. It is also seen in complement deficiencies and autoimmune diseases related to photosensitivities. Then you have SS-B, seen also in neonatal lupus. Anti-SNP is a specific marker of SLE, and it may be associated with CNS disease. However, it's not useful in monitoring therapy. RNP is generally coexisting with other anti-SNP. It's a marker of mixed connective tissue disease. So what you have to understand is that autoimmune diseases can have overlaps, right? If you have an autoimmune disease elsewhere, it's not rare to have another autoimmune presentation in other organs. Histones or antihistones is seen in 50 to 70% of patients with SLE and more than 95% in drug-induced lupus. Phospholipids like your beta-2 glycoprotein 1 antibodies is associated with the complications of thrombocytopenia and late trimester abortions and hypercoagulable states. Proliferating cell nuclear antigen or pCNA is not sensitive for the disease, but it's specific. It's not because it's not seen in RA and other connective tissue diseases. So this antibody rapidly is diminished by steroids and treatment. It correlates well with the arthritis complications of SLE. The Sjogren's is a systemic connective tissue disease, more common in women than men. So pathologically, it is an autoimmune exocrinopathy involving the lacrimal glands, salivary glands, and less often the pancreas. So immune inflammation of these glands contributes to the Zika syndrome with dry eyes and dry mouth as characteristic clinical features. So since Sjogren's can affect your lacrimal and salivary glands, there are more likely specific tests for the diagnosis of its effect, like having dry eyes. So some of the tests are listed in the table, like Schirmer's test, Rose-Bengal dye test, and tear breakup time. So it's just nice to know. For the effects of a dry mouth, so salivary gland inflammation or injury, salivary gland scintigraphy can be used. So the finding in Sjogren's for this would be a low uptake of your radionucleotide. For lower limb biopsy, under the microscope, you can see the presence of lymphoid infiltrates around salivary glands, which is consistent with the disease. MRI can also be used for direct imaging. Then general laboratory test, CBC may be useful because it's an autoimmune disease, so it's not rare to have antibodies that may be able to damage red blood cells. So it can technically lead to anemia, neutropenia, lymphopenia, and thrombocytopenia as well. So it may suggest immune destruction. Serum electrolytes and liver function may be helpful if you have suspicions of electrolyte imbalances when the kidneys are affected as well. ESR is a marker of inflammation. Urinalysis for renal involvement as well. And antibody quantification may be useful as well if polyclonality is expected. So serum and urine protein electrophoresis is also done. So transformation from polyclonal to monoclonal gammopathy may imply evolution of A-B-cell lymphoma. So markers for autoimmunity can also be measured. So if you notice, some of these are also seen in lupus. Because again, autoimmune diseases are a spectrum of diseases. You call it as such if the predominant effect is compatible with the disease. So therefore, it's not unusual to see the same repeating autoantibodies present. For example, anti-nuclear antibody. We mentioned that it's a common test, right, as a screening for autoimmune disease in general. So anti-SSA and B, rheumatoid factor even. So in the next slides, we'll discuss rheumatoid arthritis, trioglobulins, and anti-dsDNA is also present. For systemic sclerosis or scleroderma, this is characterized by excess and widespread deposition of collagen in many organs of the body. So there's fibrotic deposition. The hallmark of this pathologic process is the deposition of altered collagen in the extracellular matrix. The disorder is characterized pathologically by three features: tissue fibrosis, a proliferative and occlusive vasculopathy, and a specific autoimmune response with distinctive autoantibody profile. So there are four major subtypes or presentations for scleroderma or systemic sclerosis. One, it can present as a diffuse cutaneous scleroderma with widespread involvement of skin in visceral organs. Two, it can present as a limited cutaneous scleroderma, in which the disease is limited to the digital extremities and face. So Brest syndrome is a variant of this entity. So the name is derived from its features: calcinosis, Raynaud's syndrome, spinal dysmotility, and sclerodactyly, and telangiectasia. So localized scleroderma that affects primarily skin of the forearms, fingers, and latter of the systemic organs is another presentation. And like other autoimmune diseases, you can have overlaps with rheumatoid arthritis, for example, or muscle involvement that may be related to your inflammatory myopathies. So how do you evaluate, diagnose, work up a patient suspected of systemic sclerosis or scleroderma? Well, the first is that you can detect autoantibodies first by testing for anti-nuclear antibodies. Second is that you can request for the identification of the specific antibody sort of unique to scleroderma, one of which would be anti-SCL7. So SCL, scleroderma. So shown here is just an example of what you are actually detecting in immunofluorescence testing. So the sort of immunofluorescence pattern is identified because most antibodies will have a specific pattern of light up. You can have a homogeneous type of result, a nuclear dense fine speckled result, a centromeric type, and a diffuse type. So what are the other autoantigens present in scleroderma? You have the following. So anti-SCL or topo-1 or topoisomerase antibodies. It's seen in about 25 to 40% of patients with diffuse scleroderma. It's also associated with severe lung diseases as a complication. Anti-centromere antibody is seen in about 55% to 96% of patients with Crest syndrome. So it's also seen in Raynaud phenomenon and in about 10% of patients with primary biliary cirrhosis. Anti-RNA polymerase 123 is seen in about 4 to 20% of patients with diffuse skin disease and renal involvement and less in lung and muscle involvement. Fibrillary or fibrillary antibodies is seen in about 8% to 10% of patients with cardiopulmonary muscle involvement with a higher prevalence in Blacks and Native Americans. So PM-SEL antibodies is a nucleolar complex seen in association with inflammatory muscle disease in scleroderma. So PM stands for polymyositis. So other antibodies are listed here as well. So if you notice the pattern here, in diseases, you have other or many types of autoantibodies produced, which can be an option for testing. So moving on to inflammatory muscle diseases. So inflammation of the muscle leading to injury and weakness is the basis of the three most common but distinct diseases in this category. So the three diseases are dermatomyositis, polymyositis, and inclusion body myositis. What are the options for laboratory evaluation? So since it's an inflammatory muscular disorder, damage can lead to an increase in creatine kinase. For polymyositis, the CK concentration is elevated in about more than 50 times normal levels. It is indicative of disease activity. So the use of CK in polymyositis and dermatomyositis is similar. For inclusion body myositis, CK concentrations may be normal or elevated, but no more than 10 times the upper limit of normal. Taking muscle samples and examining under the microscope is also useful. So the inflammatory infiltrates are usually within the fascicles surrounding the healthy muscle fibers. So no perifascicular atrophy is noted in polymyositis. You can also have increased evidences of inflammatory cell injury by demonstrating your CD8 cytotoxic T cells and enhanced expression of your MHC antigens by muscle fibers, meaning that the muscle fibers are deemed and is designated as something that is harmful. That's why your MHC is trying to present them to your CD8 positive T cells. Dermatomyositis, the inflammatory infiltrate is usually around the fascicles. So the presence of perifascicular atrophy is diagnostic. So complement-mediated vascular damage is also seen. In inclusion body myositis, the pattern of inflammation is similar to polymyositis, with additional features of basophilic rimming of the vacuoles, basophilic rim vacuoles. So that is seen inside the muscle fiber, particularly in the sarcoplasmic area. The presence of all three of the following on the muscle biopsy will confirm the diagnosis of inclusion body myositis and effectively excludes other idiopathic inflammatory myositis. So the three findings are vacuolated muscle fibers with inclusions, and demonstration of paired helical fibers by EM. And the third useful laboratory marker would be anti-Jo1 antibodies. It's present in about 40% of polymyositis. Same with dermatomyositis, and also similar to inclusion body myositis. So other antibodies present in these inflammatory myositis conditions are listed here. So we mentioned your anti-Jo1. So it's seen in relatively in acute onset myositis, frequently in interstitial lung diseases as well. It's responsible for the fever, Raynaud's phenomenon, and mechanics in hand. So muscle disease dominates the picture in even those who meet criteria for SLE and RA if they express these antibodies. Anti-signal recognition particle or anti-SRP seen in very acute onset myositis with severe muscle weakness. And this antibody is seen in cases where predominantly females are affected. So in this condition, caused by these antibodies, the characteristic rashes will be absent. If the antibody associated is anti-MI-2, it is relatively acute onset type with classical rashes of dermatomyositis present, such as your B sign and Scholl sign. Anti-200-200 weirding is seen in necrotizing myopathy with minimal muscle wasting. Anti-155-140 is seen in juvenile dermatomyositis. And anti-CDAM-140 is seen in clinically amyopathic dermatomyositis causing interstitial apoptosis. So next autoimmune disease is called mixed connective tissue disease. So MCTD has some of the features of SLE, some of systemic sclerosis, and some of polymyositis, hence the name. So these patients have variable clinical presentations with arthralgias, myalgias, fatigue, and Raynaud's phenomenon. So the laboratory evaluation for mixed connective tissue disorders are seen here. So you can do and detect ANAs or anti-nuclear antibodies. It often shows a speckled type of pattern in immunofluorescence. Autoantibodies to extractable nuclear antigens or ENA is also seen. And autoantibodies that are also seen in SLE, systemic sclerosis, and polymyositis can also be present, except for anti-SMIT when it's negative. Another commonly discussed autoimmune disease is rheumatoid arthritis. So to establish a definitive diagnosis of RA, at least 3 of the following 7 criteria must be present, along with morning stiffness for a period of at least 6 weeks. So the 7 parameters are listed on the slide. We have arthritis in 3 or more small joints, morning stiffness lasting for more than 30 minutes, arthritis of small joints in the hand, the presence of rheumatoid nodules, systemic arthritis, often with cytomyces, a positive test for RF, which we'll explain next, and evidences in imaging or radiographic changes of the affected joints. So what are the tests that can be requested or is useful for rheumatoid arthritis? So CBC, again, it's an autoimmune disease. It's not there to have hematologic effects like having anemias, elevated platelets, neutropenia as well. ESR is an inflammatory marker, so naturally it may be useful for rheumatoid arthritis. An index of inflammation is often, an index of inflammation is what ESR is, and it's often elevated. So it's often parallels disease activity. Other acute phase reactants like CRP can be used as well. So this acute phase reactant is increased in RA. It is an index of inflammation useful in monitoring disease activity over time and in response to therapy. RF or rheumatoid factor titer. So rheumatoid factor is detectable in about 70 to 80% of cases of rheumatoid arthritis. However, there's diagnostic limitation for this. It is limited by its lack of specificity. And this is found in almost all patients with other autoimmune diseases like cryoglobulinemia, even with Sjogren's syndrome, and even in SLE, this is possible. So therefore, anti-CCP is more useful for antibodies against the cyclin-related peptide. So its specificity is about 95% to 99%. It is found in about 85% of cases of rheumatoid arthritis. It's also useful because it predicts erosive disease in RA. It's valuable in diagnosis of early forms. And positive titers to this have a better prognostic value. So other forms of this would be anti-cyprin-related alpha amylase and anti-cyprin-related thyroid. So there are other things that can be used to diagnose rheumatoid arthritis. So let's just choose one. Alright, so joint fluid analysis. If a single joint exhibits a heightened inflammation in a patient with polyarticular disease, you need to exclude septic arthritis crystal-induced arthritis, and consider rheumatoid arthritis for this. So radiographical studies, evidences of periarticular osteoporosis, soft tissue swelling, joint space reduction, and erosions should be determined at baseline and monitored with use of disease-modifying anti-rheumatic drugs. So MRI is sensitive as well, but may be sort of more expensive. So next autoimmune disease is amyloidosis. So amyloidosis and cryoglobulinemia are systemic diseases resulting from the deposition in the tissues of insoluble proteins from a soluble circulating precursor. Both represent the consequences of immune dysregulation, and their diagnosis depends on laboratory evaluation and confirmation. So amyloidosis is a heterogeneous group of diseases resulting from the extracellular deposition of low molecular weight fibrils from a soluble circulating precursor, giving the characteristic carnaceous and waxy appearance of organs deposited by amyloid and cryoglobulin. So what are the laboratory tests? Alright? Okay, before we go there, again in review, we have mentioned some of this in our lecture. There's a lot of types of amyloid. So these are labeled to basically differentiate them from their disease association. So more commonly, you have your beta amyloid. This is the deposit in Alzheimer's disease and aging. A amyloid is seen in chronic inflammation. Then amyloid light chain is seen in neoplasms involving your plasma cells, like multiple myeloma. Then you have the other types. So what are the options for laboratory evaluation of amyloidosis? So one is abdominal fat pad aspiration or biopsy. So this is a preferred site due to ease of obtaining multiple samples that better yield than other organs. So you can make or use a special stain to identify amyloid deposits. Next would be salivary gland biopsy, so same thing as well. Serum and urine protein electrophoresis. So primary amyloidosis is often associated with a monoclonal gammopathy, meaning that it is due to abnormally secreted immunoglobulin that deposits, more common in multiple myeloma, for example. So serum and urine electrophoresis followed by immunofixation studies to identify the specific monoclonal antibody can be helpful. Assays for serum free light chains and their ratio in serum are essential to detect light chain disease. So bone marrow biopsy is indicated when serum electrophoresis, serum free light chains, and urine electrophoresis points out a monoclonal gammopathy, a tumor, right, coming from your plasma cells as the cause of amyloidosis. You can subject the bone marrow tissue to flow cytometry and special stains for diagnosis. Having factor 10 abnormalities is also associated with amyloid deposition, particularly protein sequencing is useful for identifying genetic abnormalities in hereditary amyloidosis and identifying rare forms. Then serum amyloid P component scanning. It's a scintigraphy type of test using a radio-labeled SAP used to identify and estimate the total body burden of amyloid, or how much amyloid is being deposited. So next disease is cryoglobulinemia. It refers to the presence in the serum of one or more immunoglobulins that precipitate at a temperature below 37 and is reversible, and it redissolves on warming. So the cause of precipitation remains to be determined. So these are the options for diagnosing cryoglobulinemia. So there's a lab test called cryoprint. So this is the volume necessary to keep the temperature sample at 37 until it reaches the laboratory. Then it's refrigerated, and you basically is testing, alright, the presence of your cryoglobulin directly. Immunofixation and immunodilution is an option as well. Urinalysis is useful if you suspect that the cryoglobulinemia has already affected renal function. Measurement of your complement proteins in RF is used to assess how much complement activation is happening. Liver enzymes to evaluate potential liver damage. And hepatitis serology is useful because it is often linked, cryoglobulinemia is often linked to hepatitis B and C. then renal biopsy and lymph node biopsy to look at the sample or tissue sample and look for evidences of cryoglobulin effects. Now let's discuss the diagnostic options for immunodeficiencies. X-linked agammaglobulinemia of Bruton. In this disease, your B lymphocytes fail to mature properly in such a way that you have a deficiency in your immunoglobulins because a plasma cell is a differentiated B cell, right? So patients may be asymptomatic, however, during the progression of the disease, they are at risk for recurrent bacterial infections. So the laboratory evaluation for X-linked agammaglobulinemia is listed here. You can measure serum IgG, which is often decreased, less than 200. So you can be a carrier for this disease. Serum IgA and IgM is low to absent. B cell markers are low as well. These are mature markers. The mutated gene is BTK, so you can detect that. And because you fail to produce sufficient immunoglobulins due to an immaturity or the lack of maturation of your B cells, if you vaccinate a person suffering from XLA, it will not respond with an antibody production. So antibody responses to childhood vaccines markedly decrease to absent. You know why, right? In hyper-IgM syndrome, it's characterized by markedly reduced IgG and IgA with normal levels of normal to elevated levels of IgM. So therefore, to diagnose, you just measure the levels of your immunoglobulins. Selective IgA deficiency. So in this disease, you have IgA deficiency, so your mucosal defenses are compromised. Patients are at risk for recurrent infections, respiratory, gastrointestinal as well, and even urinary tract infections. So to diagnose, you measure the levels of IgA. So DGEORGE syndrome is a type of immunodeficiency linked to T cell function because the syndrome includes the following: cardiac anomalies, abnormal phases, and thymic hypoplasia. So your T cells are mature, differentiated, and undergo selection in the thymus, left palate, and hypocalcemia. So this deletion leads to a failure of the development of the third and fourth pharyngeal pouches and consequent abnormalities in the development of the thymus and parathyroid glands. A child with neonatal tetany and abnormal passage should be evaluated for DGEORGE. This is done by enumerating T and B cells, along with the measurement of serum calcium and parathyroid hormone. Chromosome 22 deletion is even identified by doing FISH or fluorescent in situ isolation. So diagnosis of AIDS. AIDS is caused by a retrovirus and it is characterized by profound suppression of T cell mediated immunity. It's a non-transforming retrovirus in the lentivirus family. It causes immunodeficiency by destruction of target T cells. And there are two different but generally related forms, HIV 1 and 2. So these are the components of HIV. It has a lipid envelope derived from the infected host membrane during budding. It is studded with two viral glycoproteins, 120 and 41. GP120 is very important for viral entry. The virus core contains the capsid protein P24 and other nucleocapsids. P24 is the most readily detectable viral antigen and is the target in most diagnostic antibody assays. The viral genomes can contain your typical retroviral GAG, POL, and ELN. The GAG and POL gene products are synthesized as a larger precursor proteins that must be proteolytically processed. So these are components of viral therapy. So the components of drugs, therefore, will try to target these proteins. So besides the typical retroviral GAG, POL, and ELN, HIV has several genes as well. Your TAG, VPU, VIF, etc. But more importantly, let us review the life cycle of HIV. What happens is that HIV likes to infect your CD4 positive T cells. HIV enters the cell by way of its GP120 binding to the CD4 receptor. Also, an important note is that it may also use co-receptors like CXCR4 and CCR5. So once inside, it will fuse. So before going inside, it will fuse with the host cell membrane, release its viral substances. From RNA, it will become DNA, integrate into the host DNA, make new viral particles or viral structural products, make use of the CD4 positive T cell's own membrane, bud out of it, and produce a new mature HIV. What happens to the CD4? It will be damaged and destroyed. AIDS is heralded by a rapid decline in host defenses, manifested by low CD4 counts, and a dramatic decrease in viral burden. Patients frequently presented from fever, weight loss, diarrhea, followed by serious opportunistic infections, secondary neoplasms, or neurologic diseases. These are the age-defining conditions or diseases. If you notice, right, some of these are opportunistic infections, fungal and severe forms of otherwise not severe bacterial infections. Also important to take note is that oncogenic viruses and their tumor associations are also included as age-defining conditions. Examples would be lymphomas linked to EBV, cervical cancer, HPV, Kaposi sarcoma, human herpes simplex virus A as well. So what are the stages of HIV? You have the stage of acute infection. It's a stage of exposure up to the onset of symptoms on an average about 1 to 3 weeks. At this time, the laboratory findings, you can have a starting replication of the virus inside. You may have an indeterminate or negative HIV test at this stage, and your CD4 count may start to decrease. The seroconversion stage is about 6 to 12 weeks after transmission. It's the stage of heightened immune or humoral response, and symptoms may be still low, or the patient may be asymptomatic still. So you now may start to have a decrease in plasma viral concentration, and may still have a negative indeterminate serology. The early HIV disease is the seroconversion stage, on an average 4 months after infection. May be asymptomatic, with variable CD4 and HIV RNA count. The asymptomatic infection is WHO clinical stage 1, so it's clinical asymptomatic except for persistent generalized lymphadenopathy. Early symptomatic HIV infection, WHO stage 2 and 3, is when you see evidences of immune suppression because of opportunistic infections. Examples would be candida thrush, oral hairy leukoplakia, recurrent herpes zoster, ITP, etc. Now, WHO stage 4 is AIDS stage. AIDS-defining conditions are present at this time, like BCP pneumonia, wasting, CMV disease, and the other defining diseases. Categorically, your CD4 count at this stage is less than 200, but generally more than 50. Because less than 50 is advanced HIV infection. And at this time, the patient will surely have a limited life expectancy. Virtually all patients will die of HIV-related complications. It's transmitted by direct contact with blood, body fluids, rectal, vaginal, and breast milk, having sex with someone who has the disease, anal sex, vaginal sex as well, sharing needles, other equipment. Blood transfusion, being born to an infected mother, needle sticks, oral sex, ejaculation in the mouth. Very to extremely rare would be from food or deep kissing, and it's generally accepted that it's not spread through the saliva. There's no approved vaccine yet, but there are options of pre- and post-exposure prophylaxis. So these are more of antivirals. Of course, safe sex and using condoms. So treatment of HIV and its drugs all target an important stage in its life cycle. So fusion inhibitors tries to prevent the entry of the virus. And reverse transcriptase inhibitors prevents the RNA to DNA transformation. Integrase inhibitors prevents integration of the DNA of the virus to your own DNA. And protease inhibitors permits the step of the virus making use of the CD4's membrane and going out as a new viral particle. Now, treatment of HIV and AIDS. The World Health Organization has the following guidelines. You start antiretroviral therapy if the CD4 count is less than or equal to 500. You give priority in the next conditions. So individuals with advanced or severe stages, obviously, or CD4 count of less than 350. You initiate regardless of the stage if the patient has TB, hepatitis B or C, is pregnant and breastfeeding as well. So how do you diagnose HIV? Serology is an option. It's the usual method for diagnosing. Serological tests can be divided into screening and confirmatory tests. Screening tests should be sensitive, whereas confirmatory tests should be specific. Screening assays make use of enzyme-linked immunoassay as the most frequently used methodology. The sensitivity and specificity of the presently available systems now approaches 100%, very sensitive. But it's not perfect. It can have false positive negative reactions as well. Some assays have problems in detecting the HIV-1 subtype O or 0, I think. So confirmatory test, option with the Western blot, it's still regarded as a gold standard for serologic diagnosis. However, its sensitivity is lower than screening EIAs. Lyme immunoassays incorporate virus HIV antigens in nitrocellulose strips, and the interpretation of results is similar to that of Western blot. It's actually more sensitive and specific. This is a picture of a plate using the ELISA principle for detection of antibodies. And this is an example of the diagnostic criteria results for Western blot testing. In Western blot, you are detecting not the antibody but the component of HIV. Depending on the country or the organization, they have different requirements for interpretation. For example, in, let's say, UK or in Australia. So any one of these identifies diagnostic, and any three of these. Then CDC, they also use for other parameters. So it normally takes about 4 to 6 weeks before HIV antibody appears following exposure. So you should be aware of that. A diagnosis of HIV infection may be made earlier by detecting the antigen. However, there are very few circumstances when this is justified. Except, for example, in babies born of HIV-infected mothers. What are the prognostic tests? You can test for the viral load. You can do this by PCR. HIV viral load has now been established as having a good prognostic value and in monitoring response to antiviral therapy. And of course, of utmost importance is determining the CD4 count because it correlates with the degree of immune suppression. So this is the sort of immune response steps or temporal timeline in HIV. Right, so the next short PowerPoint is about drug testing.
Great. You need the next PowerPoint.
Lucy.
You need the next PowerPoint.
Alright, drug testing. So these are the objectives of the short lecture. We're going to discuss the legal concerns, aspects of drug testing, define the types, define the principles of drug testing, and define patient preparation and its procedure. So in our country at least, who undergoes drug testing? So mandatory drug tests are done in applicants for firearms license, permit to carry, officers and members of the military, police, and other law enforcement or law enforcers, in candidate for public office, and persons apprehended for violation of your RA 6165, that is, if I'm not mistaken, the Dangerous Drugs Act in the Philippines. So all persons who by nature of their profession carry firearms, like your security guards, need to be drug tested. I'm sure you know why. So all persons charged before the prosecutor's office with an offense having an imposable penalty of imprisonment of not less than 6 years and 1 day need to be drug tested. So what about random drug testing? So it will depend on the institution. So students of secondary and tertiary schools and officers or employees of government and private offices. For students, it can be part of the handbook or rules and regulations. And for private employees, it can be a part of the company policy. So it's HR related as well. So in doing drug testing, so what are the different objectives or purpose of the test? So one is to know, if present, what are the metabolites? If present, how much of the target analytes are present, its range. And alright, what appropriate analytical tool can be employed? So what drugs are tested? It will depend on the kit and the availability of the lab. So the most commonly tested drugs are marijuana, cocaine, amphetamine, opiates, and PCP. Other popular tests may also include methamphetamine, benzodiazepine, barbiturates, oxycodone, and ecstasy or MDA. Okay, so what specimens or samples can drugs or dangerous drugs or illicit drugs be detected from? So blood, fingernails, hair, saliva, sweat, tissue. But almost 99% of screening and testing for illicit drugs uses urine. Why? Well, at least in our country, urine specimen is least expensive and most popular. It's easy to do. In our health department, they have standardized the procedure for urine drug testing. It detects use within the week, and abstaining can produce negative reactions. So these are some limitations. And also the advantage of urine is that the kits now in the country has been established and been validated, so that their sensitivity, specificity, and accuracy are known to the health department. What about blood? Blood can be used, however, the methodology is expensive, the most expensive method. However, it is the most accurate method. It's not that common, and it has a short detection time. In our country, the protocol and procedure is not yet established and standardized, however. For hair specimen, it is expensive and tedious as well. It is said to be 2 times more sensitive than the urine test. It does not detect recent use, because the principle of this is that the metabolites of the illicit or illegal drug on chronic use is said to be deposited on hair. So therefore, it's more useful for detecting chronic abusers. It requires as little as 1.5 by 1.5 cm of a hair clump. It is not affected by drug abstinence, because you're detecting the metabolite or particle that's already been deposited in the hair. So therefore, it's useful in determining the temporal pattern of when or how chronic or how severe the drug dependency of the patient is. So saliva. Saliva is an uncommon method. However, it's said to be easy to administer with a short detection time. In our country, there's still no reference standard, sadly. Sweat patch specimen requires wearing of patch for 1 to 2 weeks, so not practical. It's an uncommon method, no established standards yet, and because it's a patch in the skin, surface contamination can cause false positive results. It can be used for detection, can detect use for extended period of time, however. That's one advantage. So how do you collect the urine specimen? You can either be an observed collection or an unobserved collection. So in an observed collection, you do it in a hospital or lab. You're asked to collect urine in an open urinal. It's not that they can see you, but the doors are open. And the urinal does not have a water source. The urinal is a water-free urinal. The washing area is outside of their collection. You know why, probably. That is to prevent contamination or tampering of the urine specimen or dilution. So if some of you underwent drug testing, you're even asked to empty your pockets. Another option is an unobserved collection. So this is done in the absence of a collector, where you just submit the sample. However, your urine sample here will still be tested for validity and look for evidence of tampering. So the types of specimen collection can be a single collection. In drug testing, you're asked to completely fill the required volume, right, in the 60 ml bottle. Or it can be split into just two separate containers, 30 ml each. Now let's discuss the screening phase. So what is a screening drug testing test? It's a qualitative test. It's a laboratory that performs a validated test to differentiate a negative specimen from a specimen that requires further testing for drugs or metabolite. So you have to understand that the drug testing there in your general laboratories are screening tests. If you are found positive for a drug, it is mandated by law that the laboratory will need to send your specimen to a confirmatory laboratory area, a confirmatory lab. It's a bigger lab with a more sophisticated way of detecting the drugs, usually mass spectroscopy and gas chromatography. So what are the analytical techniques employed by screening test? So the method may be one, a registered testing kit approved by the BFAD of our Department of Health, so that's like the FDA, or an instrumented screening method. For the majority of the laboratories here, they use a kit, a drug test kit. A drug test kit is an easy, fast, quantitative, visually read. Okay, the principle is competitive binding immunoassay method, and it's used for screening. So you don't need the machine, you just need the kit and the urine of the patient. So what's the principle of the test? So it's an antigen-antibody interaction. So by utilizing an antibody that is specific to different drug classes, the test permits independent detection of drug from the sample. So what actually happens here? So the urine will mix with a labeled antibody dye conjugate and migrates along a porous membrane. So if the concentration of the drug is below the cut-off detection limit, the unbound antibody dye conjugate, right, binds to antigen conjugate immobilized on the membrane, producing a rose pink color band in the test zone. So in short, there's a dye in here that when you drop the urine, it will flow through the porous membrane and reach the control area and the test area. If you do not have the high level of drug in your urine, okay, the flow of the urine, so there's an antibody dye in these areas, and there's an antigen conjugate immobilized in the membrane here. So as the urine flows, it will reach the control area and it will reach the test area. So the antigen that is present in the kit will travel to the test area where the antibody is. So binding of the antigen in the kit to the antibody in this area will cause a colorimetric reaction. So you are negative for the drug. Okay? If you have high concentrations of the drug, if you drop the urine, the drug will compete with the antigen also present. So as it flows, it will compete and not cause a colorimetric band in the area. So in drug testing interpretation, it's the reverse of what your usual kits are. a negative test indicates a ban, and a positive test indicates an absent ban in the testing area. So if the concentration of drug is at or above the cutoff detection limit, free drug competes with the immobilized antigen conjugate on the membrane by binding to the dye. So this will form an antigen-antibody complex, preventing the development of the loose-colored pink band. So regardless of the drug levels in the sample, a rose pink color band is produced in each control zone by a parallel immunochemical reaction. This band serves as built-in quality control measures by demonstrating antibody recognition, verifying that the reagents are chemically active. So what does this mean? For the test to become valid, the control area should have a band. So in this test, you have a band present, so the patient is negative for the drug. In this test, no band formation, so it's positive. But the control is positive, so this test means that the strip is working. On the other hand, this test is invalid because even though you had a bar at the test area, the control area did not produce any bar. So this test strip is defective. It is defective. So you repeat the test. So a presumptive positive are samples with concentration at or above the cutoff level. A presumptive negative are samples with concentration below the cutoff level. A negative result does not mean the absence of the drug. It means that the drug in the circulation, if there's a drug, is at a very low concentration. So different countries have different cutoff screenings for different drugs. So listed here, we have amphetamines, marijuana, cocaine, opiates, and your fentanyl. Now the detection times and cutoff. For marijuana, the detection window is about 2 days to 3 weeks. For cocaine, it's about 2 to 3 days. Opiates, 2 to 3 days. Amphetamine, 2 to 3 days. PCP, 8 days to 3 weeks. Amphetamines, 2 to 3 days. And benzodiazepine for 3 or more days. So outside of these ranges, there's a high possibility of testing negative for these drugs. So the confirmatory phase is when you tested positive for the screening procedure and a second analytical procedure is done. So the purpose of this confirmatory test is to identify the presence of the specific drug or metabolite which is independent of the initial test. It uses a different technique and chemical principle from that of the initial test in order to ensure reliability and accuracy. So the test in here will be gas chromatography and mass spectroscopy. Right, so let's look at a sample video here.
Nothing yet. Not yet.
Okay.
DAU, also known as the drugs of abuse urine.
Okay, so this drug test kit measures methamphetamine, opiates, marijuana, and other tests. Benzodiazepines, cocaine, and what's the MP? Amphetamine.
I mean,
Alright.
Okay, so I'm just going to be actually using the positive QC because I want you to see what it looks like. But what it is a rapid card that is going to test a patient's urine for amphetamines, benzodiazepine, cocaine, amphetamine, metabolite of marijuana. Okay, so we're going to bring it to room temperature. It should actually be stored at room temperature. Alright. It's okay to bend them because this is a very small amount in here. So 1,000, 2, 1,000, 3, 1,000, 4, 1,000, 5, 1,000, 6, 1,000, 7, 1,000, 8, 1,000, 9, 1,000, 10, 1,000. It's okay to back that a little bit because there was hardly any red in there. Okay, I'm gonna cover it back up. Now, the weird thing about this card is that if you look at the interpretation on it, on the cover, it says that when you have a control line and a test line that are there, it says that it's negative, whereas the control line alone is positive, which is totally weird because that usually is not what you would expect to see. So, just like chromatography, the liquid is going up, and if
chromatographic,
the
yes.
protein that's there is going to bind to
Positive for
an antibody that is for that antigen, and it's going to
It's Japanese. I can't read the
If
It's
it's there alone, it's going to be positive, and if it's just the test line, that means it's invalid. So you would then have to do it again from the same lot, and then if it's not, if that still doesn't work out as expected, then you can go to a different lot and perform your QC. Okay, so see the fourth one over, the amphetamine.
He's using every drug, I
Is
think.
going to be positive even it has a faint line right now, but when you
Even
see a faint line like that, it still means that the line is present.
everything is possible.
That means
He's a drug dealer, I think.
again, this is positive.
You know what drug
This is
dealer?
positive.
This place of drug dealers will
We're still
usually
waiting on the time.
drug dealers will
Currently,
usually
I could say they
Don't
are
do that
positive.
anything.
We'll wait.
Okay, so all of the drugs are present in here, so possibly because the person here made use of a positive control. Okay, so again, the principle is competitive antibody binding. So if you have high levels of the drug, so the drug will bind with the antibody, right, preventing the conjugate antigen inside the kit to form the red part. Right, so that's an example
I'll
of
get back to you.
a drug testing kit.
It's expired.
Right, so obviously in here, so no line was formed, not even a faint line. So interpret this as all of the drugs was
Positive.
present in the sample. But the sample used here is a positive group. So you expect all the parameters to be positive.
How many are we going to find here?
0.
Right, so that's drug testing. Check the attendance.